So I am so pleased and proud to introduce these two fine women and genetic counselors. I say proud because they're graduates of University of Arkansas Medical Sciences Genetic Counseling Program, and so I'm proud of them in that respect. But you know, that was many years ago, and both of these women have forged their careers, have performed at excellent levels, have experience both in clinical practice, laboratory utility, industry, and I really view them absolutely, it's not just my personal opinion, they are experts in what they are going to present to you today. And just to set the stage for those who may be new, you know, and don't know about this project, I'll just briefly set the stage. Then Erin, I will turn it over to you to introduce Julie, I guess, or I guess Julie's going to present first, and I'm not sure how you two are going to do that, but let me just give you a brief context for this project and why they are presenting. So briefly, in the past, the Heartland Regional Genetics Network, as well as other regional genetics networks, have tried to really integrate genetics and genomic testing into primary care. And one of the barriers that crossed regions and crossed implementation strategies within our region was the fact that whether they were in a specialty practice or a primary care practice within a medical system or in a rural area in their own private practice, there were barriers to ordering genetic testing, one of which was navigating the pre-authorization process, who's going to end up paying for this test, et cetera, et cetera. And that was frankly a roadblock to implementing some of the practice models we had hoped to implement, and where there had been interest on both parties, both the genetic side and the primary care side. So what we did was take a step back and say, all right, we may not solve this entirely, but what can we do to begin to better understand this phenomenon? What can we do? If we understand it, then maybe we can identify strategies that could at least mitigate some of these barriers and still allow proper guided genetic testing within a patient's community before they see the specialist, be that the genetic counselor or the medical geneticist. That has now resulted in a clinical services work group with a subgroup involved in this laboratory pre-authorization. Erin Beaver, who is one of your speakers today, is chair of that group, and Julie Kaler, the other speaker, has contributed significantly, bringing her expertise to the table, really around the insurance side of things. And so they, our region, this lab subgroup, has developed tools and resources for you, which Erin will be showing you today. We have not made
Lori, you've muted yourself.
Okay. This webinar is being recorded. Pardon?
You were muted there. You're good now.
Okay. The webinar is being recorded, and it will also be posted on the website with those resources. We had, for Julie and Erin to know, we had a lot of interest in this across the country, but some people couldn't make it because they just found out about it on short notice, and there were many requests for this webinar to be recorded. Now, I have not done justice to these women's careers and proper introductions, but I don't want to also take up additional time. I just want to assure you that they have contributed heavily. They know what they're talking about, and they bring over 10 years of expertise and practice to this topic. And so, Erin, I will turn it over to you to introduce Julie.
All right, thank you, Lori, for that warm introduction. So Julie is going to be our first speaker today. Julie is one of my former classmates, and I consider her a good friend. She has many years of experience, not just in clinic, but also in industry. And from that industry experience, she's going to be bringing the knowledge that she's sharing with us today on how to maximize your impact and prior authorizations, including letters of medical necessity and sometimes saying no. And then after Julie presents, I will show you some tools that we have designed in our committee. And Julie has been a very integral part of that and has taken on a large load of designing many of these pieces. I'll be demonstrating those. They will be going up on our webinar. So, all right, Julie, take it away.
Great. And Erin, if I am eating into your time to present the tools, absolutely let me know. Jules, can you wrap it up? So I will wax philosophical if given too much of a chance. Thank you all so much for engaging with this topic. It can be really challenging as providers who prioritize access and getting the patient what they need. We had great training and great modeling about how to go to the ends of the earth to get a diagnosis for a family. What we might have lacked historically in our profession and in training as well is maybe that other side of how logistically our efforts are moving through the system and what efforts are more or less likely to make an impact. And so it is my hope, having worked both in a Arkansas Children's Hospital in a clinical setting, and then also for insurance carriers doing the prior authorization reviews. I was one of the people reading your letters of medical necessity. I think there's a lot of opportunity for efficiency. So that's what I hope to get into today. I think it helps to take a step back and understand payer policy decision making. And this is true for Medicaid and commercial payers, but a lot of my content will be specific to commercial payers, though there are some themes that are common throughout. So what is a covered service? Sometimes I would call Blue Cross plan and give them CPT codes, and they would say, yes, those codes are covered. And as a new baby genetic counselor, I would think, ooh, yay, great. But what that means is that a covered service has a contract between the purchaser and the health plan, that it is part of that contract. It doesn't necessarily mean that it will be paid for. Some contracts may specify other categorical exclusions. So genetic testing can fall into this. I think we all remember TRICARE for the longest time did not cover or include genetic testing. It was outside of the contract. Other services that can sometimes be excluded are cosmetic services, long-term skilled nursing. So it's not anything new. It's just something that genetics sometimes can be involved in. Once a service is contracted to be covered with a health plan and the purchaser, then that service is under an assessment of medical necessity. And the common definition for medical necessity is that a service must be reasonable and necessary for the diagnosis and treatment of an illness or injury. However, each individual payer may expand on that common definition to say medical necessary means you have to start or stop some service or treatment. Evidence review to write policy and to do these medical necessity assessments of genetic tests, they require analysis of professional guidelines, clinical studies, cost analysis, systematic reviews, basically a wealth of evidence. This is wildly inconsistent among payers. Not every payer looks at the same type of evidence or the same amount of evidence. Recently tried to get a payer to review a new article, and they said it doesn't have a PubMed ID number yet. And I said, yeah, it's a brand new article. It just hasn't been indexed, but here's the PDF of the peer-reviewed article. And they were like, no, we need a PubMed ID. So there's no rhyme or reason necessarily as to what evidence will be taken. into account. But how can you use this information to help your patient and understand the coverage for your patient? You can call the insurer and investigate whether all the CPT codes of a test are covered. And that will let you know, if there's a policy or a medical necessity assessment available for that. If they say, no, it's not covered, that's a do not pass go. Any further advocacy of coverage or payment will not be worth your time or your patient's time. You can access the payer policy if one exists, which for most genetic testing, there will be something to look at. You can do this by Googling. You can do this by calling up your payer, or you can call your handy dandy lab. Each lab has a department for reimbursement or market access, and they often are very well versed in the payer policies. So you need that policy in front of you to know, is this test ever covered? Is it ever considered medically necessary? Or does it have that horrible phrase, investigational, experimental, unproven? So if you see a microarray is considered medically necessary for certain scenarios, you can see, okay, does my patient meet these scenarios? You're a good provider. If you're thinking of ordering it, they probably do. But if you see that microarray or exome is considered investigational, experimental, or unproven, this is not really your battle to fight. And we'll talk about that in a little bit, about why this isn't really your battle to fight. That can be done at a higher level of advocacy. So if a policy considers a test experimental, unproven, go ahead and advise that patient that it is unlikely to be paid for. And you can have that conversation about whether it's worthwhile to continue. And then if there are coverage criteria, address each of those in your either clinic note or letter of medical necessity. That will be so helpful in streamlining the process and avoiding back and forth or an inappropriate denial. So here's an example of 2 payer policies on exome sequencing, and these are live payer policies. So one, it covers with medical necessity criteria, which are listed there in the bullet points. These are typical criteria, going to impact clinical decision-making, no other causative circumstances, there's not a teratogenic cause or something like that. And then there's another payer policy where whole exome sequencing is considered investigational and not medically necessary for all clinical scenarios. It is not worth the time, headache, stress to proceed with a letter of medical necessity for a payer policy this way. As smart and effective and convincing as we are as individual providers, our ability to change, especially a big payer policy on a case-by-case basis, is very limited. I'm sure we all have some anecdotal evidence of when it worked for us, but by and large, rule of thumb, if you see this in a policy, it's not going to be covered, no matter how convincing your case is. So maybe there are some different things that you can do. But if there are medical necessity criteria, it's important that you address each of those, either in your clinic note or in a letter of medical necessity, and speak specifically to the things outlined in policy. So instead of saying, whole exome sequencing will change the medical management for my patient, that is not going to convince a reviewer like myself or a medical director at a payer. Instead, please try and tell us to the best of your ability what treatment, testing, imaging, surveillance would be started or stopped based on this, on a diagnosis. And in exome, we don't really know what we don't know. So you can say, currently the treatment plan is for them to see cardiology and neurology and get yearly brain imaging. If a diagnosis is made, I may change the cadence of those specialist evaluations. And you can just kind of go criteria by criterion and answer how your patient's case meets that. No, there's no specific syndrome. fitting the presentation. There's too many in the differential. So when you think about a letter of medical necessity, that can really be helpful for you. The purpose of that document and the time that it takes to craft that document is to improve the likelihood of authorization or approval. So this can help supplement clinical records. If you didn't have the payer policy handy whenever you were dictating your clinic note, or if you're helping neurology out by facilitating an exome order and they didn't dictate medical necessity, you can supplement those clinical records with a letter of medical necessity, which really hits those policy points. I say policy because you should never write a letter of medical necessity that isn't specific to that patient's coverage policy. That would be, you might get coverage that way, but it's not as efficient as we could be. So demonstrate in your letter why this test meets medical necessity criteria in the payer policy. You can see how if it's an investigational policy, we're not going to get there. And then why this test at this time for this patient. And if there's an exceptional circumstance, really articulate that, how language in the policy doesn't capture the case of your patient. So to help save us all time and stress and reduce burnout, I'm giving you permission not to write letters of medical necessity sometimes. And think about this critically. This is when these documents are not going to be helpful. If your clinical records clearly articulate all the necessary information, good for you, good for your providers. You don't need a LMN unless you just, have an urge to write one. When the patient's health plan has an exclusion, it's not covered, not a covered service, this isn't going to be helpful for you. There are other avenues of activities you can take that are going to be more likely to yield a result. And then, if you can't clearly say that the patient meets medical necessity criteria, it's not going to be likely to get approved. So articulating this in a letter is also not very likely to be helpful. So what are we looking for? We're looking for patient-specific, detailed accounts of that patient, test-specific, but not like lab form test-specific, but like I chose this test because it's as targeted as possible, but still gets all the skeletal dysplasias I'm concerned about. And what specific medical management changes for this patient would be considered, not patients at whole, but for this patient, what might happen. And then what things are unnecessary or counterproductive. Template letters aren't super helpful. You'd be much better served writing a single paragraph informed by the payer policy. And excess information about the condition or the test usually isn't super necessary. Just hit those policy points. Speaking about parental or patient anxiety, that's not a helpful phrase, even though I understand that is a valuable benefit of testing. But instead, think about this. Think about what actions a parent or patient might take with that information. Would they change schools? Would they get services? Would they change pediatricians? And then the ending the diagnostic odyssey is another phrase we use, but it's not specific enough to move the needle for approval or denial. So think about, instead of ending the diagnostic odyssey, what might change as a result of that? And then if you just disagree with their policy, if it's an exclusion or investigational policy, and you're like, exome is not investigational, an LMN is not going to help that way, there are other ways that you can explore helping. And I won't go into the details because this is available via the toolkit, but we have a flow chart to equip you with your clinic on what activities or actions are available to you if in this red bucket coverage is not possible. Maybe we don't do a letter of medical necessity because that wouldn't be a great use of our time. Instead, maybe we collect cases in a tracking sheet, get together with other local providers and see if they can add cases to this, and then engage your government relations at your institution to meet with the medical director and go through all the patients who could have had this testing but didn't. All right, and out of thoughts of time, we have another concept, and this is saying no. It's hard, but it's okay sometimes. So let's work out a few ways in which it might be helpful. And Erin, I plan on spending maybe 5 to 7 minutes kind of going through so that you have time. Is that okay? Okay, perfect. So I won't go through all of this and read it. We'll certainly share these slides with anyone who's interested. But just know it feels hard to say no because we're such good people, because we have care and empathy. But perhaps in our training or in our practice or in our real lives, codependents, raise your hands, you don't have great modeling for saying no. And so there are some really great scripting ways that you can kind of practice and have in your back pocket that we can talk through today. But essentially, you are the expert that this patient is here to see, and you are well within your rights to decline a test. You have the skills and ability and discernment to do so in a caring and loving way. And this is uncomfortable for patients and for us. We don't like the idea of maybe not doing something. So be aware of that and then anticipate that in your conversations. So an ounce of prevention is worth a pound of cure. If you can set up the expectation that not everyone that comes to clinic gets genetic testing, that can go a long way in backing off some of those emotions if genetic testing is not indicated. So you can tell your family, it's like, thank you for coming to see us. We don't do testing for everyone, but we will see if it makes sense. Or our clinic sees many patients with Ehlers-Danlos syndrome. Some need DNA testing and some don't. And if we think it's necessary, we're going to work hard to coordinate that. But if not, we will still have a medical plan of treatment for you. You're going to get the care you need. When patients expect genetic testing, and that's why they're there, my pediatrician told me I was coming here for testing. It sounds like you're worried about, Coffin-Cyrus syndrome and that you've done a lot of research about it. There are expert guidelines for this syndrome, and your insurance has a policy for it. So today we'll go through everything and we'll determine if testing is necessary. There's lots of different ways that you can kind of let them know testing isn't guaranteed for everybody, either because of clinical presentation or payer policy makeup. Sometimes testing is not indicated. You determine, we've got EDS hypermobile type. We don't need to do genetic testing for that, or we have a pretty solid clinical diagnosis and efficient use of resource means we don't need to confirm that. You can explain, for some patients, testing would be appropriate, but here are the reasons why I think it's not appropriate for this right now. Or, I looked at the guidelines that we use to see if a patient should be tested for neurofibromatosis. And while cafe au lait spots are one of those things, we're missing a lot. And so I really don't think that we're meeting guidelines for this. Sometimes a family member is a better option. So you might say, let's explore reaching out the family history. It's definitely significant. But this other person in the family would be more informative for us to test. If your goal is to find out whether you're at risk or not, testing this person is the best way to get that answer. Sometimes the patient does not meet the policy or, clinical guidelines. So you can say, hey, it sounds like testing for breast cancer is really important to you, but without a family history and without these other factors, it doesn't seem like you meet your health plan's policy. If you still think this information is valuable, would you be interested in exploring self-pay or paying for this testing yourself? If so, yes, coordinate. If not, okay, I do understand. That's a lot of money. I know you wanted this testing, but it seems like that has a limit. Am I right? Okay, maybe we can look into research or other avenues. And then sometimes we can say, genetic testing is new and promising, but it doesn't always give us the answer. That's why we have good guidelines to help us decide who to test and who not to. And for these reasons, we don't feel like testing is necessary, or that your health plan won't cover it. And this is our situation right now. And sometimes no testing is needed. And we can say, I know you were expecting some testing today, but I feel really reassured by your symptoms, family history, that this is not concerning of a genetic condition. Your risk of this is no different than anyone else. Or you have some symptoms of that. I understand why you would be concerned. However, after the doctor's exam and my evaluation of your family history today, I don't think this particular syndrome is a chief concern of ours. So we wouldn't recommend testing. I blew through that fast on purpose. We can revisit anything or enable discussion as preferred, but I also wanted to save Erin all the time she might need for the toolkit resources.
Thank you, Julie. That was a wonderful presentation. And we will have time for questions at the end. So be sure to save those to the end. I'm going to demonstrate some of the tools that our prior authorization committee has put together. And just to recognize the individuals that have put in so much work on that committee, I want to go ahead and let you know who those individuals are. So besides Julie and myself, Anne Chow has been one of the main people in that as well. Brittany Hinson, Erin Royer, Kristen Fischler, Lori Dean, Linda Manwaring, and Molly. I think that her name is Stetler now, but it was Molly Snyder. So thank you to all of our committee members who have contributed to these tools. To kind of give you an overview, so Julie's conversation and presentation today is really meant to be an introduction to how we can streamline prior authorization processes for our providers across Heartland region. And this group, like I have mentioned, put together a number of really great tools. These tools will reside on the website. So we're in the process of getting those moved to the Heartland website, which will be quite nice and then be easily accessible to everyone. One of the other things that I want to make sure that you know is that when that is on the website, we will also have a link where providers can give feedback to us and also contribute to those toolkits even further. So perhaps they have some templates from letters of medical necessity, or maybe they have an update to our sponsored testing list, or an update to a payer resource. All of that information can be given to us as feedback in one of these links. But first, we're going to take a look at some of those resources. Okay. All right, so I'm sharing my screen now. And here, this is part of the presentation that Julie gave, sharing her flow chart, just an overview of how to navigate when a patient needs genetic testing, what do you do next? So you have a series of decision trees and questions here to help you think through that process. And then once you have checked in with that patient's payer with their insurance policy, what to do if perhaps coverage of that testing is not available. What are the other options? Where to go next? But also, if it is covered, then how you go about navigating that process as well. Part of our toolkit further, which was also provided by Julie, is a what I will call, it is a payer resource, but it's sort of a cheat sheet for payer policies. So what we plan to do is, again, because of feedback that we hope to be getting from providers that are using the toolkit, we will be able to compile a list of common payers across the region. We've already started to put together that list, and this is an example of what this payer resource will look like. So this one happens to be for Blue Cross Blue Shield of Arkansas, but we will have easy links and explanation to their policies that affect genetic testing. So you can see that here. You could easily check out, let's say you have a patient coming in with seizures, you want to check out the epilepsy related policies. And so it would be right there. So it's a very easy resource and quick resource for accessing the actual policies that are present for payers. Next one I'm going to share, that's part of our toolkit, is a step-by-step on how to do prior authorizations. Okay. All right. So many of us run prior authorizations or have ran prior authorizations in the past and probably are intimately aware of this process. But this is a major roadblock for providers' offices that do not regularly run prior authorizations. So I think specialty offices know about this because they're a specialty office. So some part of their process, whether it's a procedure or a test, has a required prior authorization. And so the process for genetic testing prior authorization is really no different than what you would experience with something like getting an authorization for a surgery or maybe for like an imaging of some kind. But their primary care offices and some other like family medicine offices where they may actually want to be ordering or helping to order genetic testing for their patients. And this is not a common practice for them. Also, obviously, there's turnover in offices. So having a tool that's easy to help train new individuals in an office is going to be helpful. And so help to streamline that overall process. So that's the idea behind this. This tool is a step-by-step how-to on how to get a prior authorization from insurance. Excuse the formatting, my Mac does not like documents from Word, or so it does look a little funny on the Mac, but it won't on our website. But through this resource, it tells you what to gather together in order to start the process with the insurance, how you contact the insurance. It gives you some information about different insurance companies and what they may require of you or ask of you. So sometimes it's a phone call, but sometimes you may call the insurance company and they say, oh, you have to fill out this specific form. So learning what the process is for different payers is kind of part of the game. And then keeping that as an easy reference for your office, if that's a common payer that you work with, would be good. So you see here, there's some quick tips. One thing that Julie mentioned in her presentation was that for providers, that sometimes if they have all of the information that you need for a prior authorization inside their medical chart notes, then you don't actually have to have a letter of medical necessity. And this was something that I learned when I was working in pediatric clinic, but I think it's really useful for anybody. So, and part of this, it does involve training your provider. So if you are not the person that is writing the clinic note, which often in pediatric clinic, it's not a genetic counselor, it's that actually the physician, whether it's a medical geneticist or maybe a developmental pediatrician or neurologist, make sure that they address these pieces, the criterion that you know for a payer, and go large. So whatever the most criterion is for one of your common payers, that's what you want to make sure that they're putting into their notes, their clinic notes. And so when you do that, then again, it's streamlined your process and the other support staff in your office, because now somebody isn't having to pick little pieces out of a medical chart note and make a letter of medical necessity. So some payers will be perfectly fine with having that chart note if they're done so thoroughly. Others, though, may still require you to have a letter of medical necessity, and we'll address that in a minute. There are common questions that come up around this process. So there is a column here that addresses that, including what is a peer-to-peer review? And what do I do if the testing is denied? And does a prior authorization guarantee coverage of claims? So again, this is just a quick reference, step-by-step guide to how to do a prior authorization. All right, and our next resource is elements of a letter of medical necessity. So this was put together in the case that you may have to actually put together a letter of medical necessity because that payer requires an actual letter. Or maybe your provider is not willing to change their notes. And so you're still having to do this process, which is totally fine. It just does take some time. So we've tried to streamline that process for you. So these are the elements that you would need in the typical letter of medical necessity. They're outlined here. They're very similar to that first column that you had on the just gathering your information for a prior auth. But in addition to this particular tool, we're also going to have templates available. So we've already started compiling those, and we do have a couple of contributions to the templates for medical letters of medical necessity. But again, providers can contribute to this toolkit as well. So if you have a letter of medical necessity template that you like to use and you want to share it with us, please do. We are going to have that link on the website, but in the meantime, if you'd like to reach out to Kara, then she's helping us to compile that list of templates. And then the next thing that we have, so in the event that you have a patient and you've walked through this process and the testing that you wanted to do for them is not covered by their payer, by their insurance company, but they still want to do some testing and you want to explore if there's other options that are available. We are going to have, as part of our toolkit, a database of sponsored testing options. Sponsored testing is testing that is paid for usually from a company and industry. So oftentimes it's pharmaceutical companies, but it may be other companies. It can also be foundations. For example, one of the tests that's on here is from the Parent Project Muscular Dystrophy. So there's lots of ways that testing may be sponsored, but essentially what that means is that it's no cost to the patient and there's no need to charge insurance. It's being paid for from a fund or by a company for charitable contribution. So we want to keep an up-to-date list. This is something that changes all the time. So again, we are going to rely a bit on providers to help us keep this list updated. So if you know of a sponsored test and you don't see it on our database, please feel free to reach out to us when that's up on the website, or if you want to just make sure that we have your favorite sponsored test that you use on our first launch, please reach out to Kara. But otherwise, we will have a link on the website once we have the toolkit up. And then what's more to come in the future? So pieces that we're still working on that we hope to have uploaded soon are patient and family resources. So what we're working on there is a glossary of terms that are surrounding the insurance and prior authorization pieces. So what is a deductible? What is a prior authorization? Just basic pieces of information around that. And then the other thing that we hope to have are tips for families that are related to the insurance prior authorization process and how they can help advocate alongside their provider for the testing that's being recommended. And so again, that both of these areas are areas where we want to get provider feedback. So we will have that feedback tool. Please help us know if you know of great tips that are helpful for patients and their families in regards to insurance and prior authorizations. And that is our toolkit in a nutshell, but we would love to hear any questions that you might have or discussion points from Julie's presentation, as well as any feedback that you have or questions about the toolkit.
This is Luba. I just want to thank you for an excellent presentation. I mean, it's very interesting. I've been writing these letters for a long time, and it's just, I just do it. I don't know why I do it the way I do it. You kind of made it all make sense. So wish I had this 25 years ago. Anyway, I think this is an excellent topic. I'm just curious. I mean, do you think primary care providers really want to spend time writing these LMNs? Do you have any feedback from them?
So I'll speak a little bit to my experience working as the back end of a prior authorization portal. So okay. Providers or provider staff went in, answered questions. So medical geneticists ordered only 8% of testing. The vast majority of testing came through oncology and OBGYN. And primary care was quite infrequent as well. And so, no, I don't think any primary care doctor, any family medicine practitioner out there has time, energy, bandwidth to do an LMN. I don't think that is efficient for them at all. As genetic testing becomes more common and integrated in primary care, I think we are going to see that support staff taking on this role of prior authorization for genetic testing.
Right.
I think it's one reason why it's really important for genetics providers to have an available resource hotline, periodic education with the local community providers, because it can really help them navigate. It's my 2 cents. I'm sorry if I skirted around your question.
No, that was a good answer. The other question I have is this, these portals where you're having to sort of, if you're an institution, you could have a primary person who's doing your auths for you if you're having a geneticist. But if you've got, if we're trying to represent the needs of a primary care physician, we can't put them in there. It's challenging. Is this the wave of the future? That's my question.
I kind of think it is, in that everyone hates prior auth, and prior auth is dead. Long live prior auth. But the payers themselves, they are struggling to keep up with genetic testing and policy and guidelines. So they are outsourcing it more now than ever. So similar to how Medicare has one unified policy set, more and more through these benefit managers like Evacor, AIM Specialty Health, Avalon, we're getting more management by these groups instead of individual payer groups. So I think the prior auth portals are probably going to grow. And there's actually a third ancillary business that's popping up. Things like Cover My Test, where these primary care or OBGYN offices that don't have prior auth or genetic support contract with these other companies to go through the portal on their behalf. So you send over your clinic note, and these companies go through the portal on your behalf. So it's kind of leading to all these ancillary companies probably driving up healthcare costs.
And they obviously give them permission to use their, Thank you. It's a very nice presentation.
Thanks. Yes, Luba, one thing that you were mentioning there at the end, it's completely accurate that there does have to be a contract typically between either the provider and that outsourced group that's doing the prior authorization, or occasionally between a lab and them. Usually it's the provider and that outsourced company.
So is that why we're seeing laboratories doing those prior auths? Using those, getting around that? You think that's why that's happening?
I think it is. But many of the laboratories still are actually outsourcing that process, even if they don't talk about it regularly. My experience in industry, and Julie, you can speak to your experience in industry, there is usually an outsourcing of the prior authorizations.
One of the main portals does not allow laboratories to enter the data, which I see both sides of that. One, you don't have the opportunity to reach out to the provider directly to clarify, but also two, we're missing the efficiency. Many laboratories now have medical necessity criteria on the test requisition form and have a statement of the physician attesting that this is true and accurate. So if a lab can enter that same data, I feel like that would be highly efficient, but we might lose out on ability to reach the provider and say, hey, we were missing this. Can you clear it up for me really quickly? Thank you.
Lori, it looks like your hand's up for a question.
Yes, thank you, Erin. Thank you both for just an excellent presentation. But I wanted to just alert the group that we are first of the year going to open up an ECHO series using the ECHO learning model. around laboratory pre-authorization. So in addition to what Erin presented with the toolkit, our ECHO series, so as you, if any of you are practitioners, I know Luba is, I don't know the others on the call, but any of you are practitioners, and you have cases that have really stumped you, or you're in the midst of one and you need some guidance, we will be inviting later, in a couple months probably, we will open up an invitation for cases to be submitted. And we'll be using the ECHO learning model, which I'll explain in that invitation, to basically it's case-based learning. So we'll have experts like Julie and Erin and others who will work with you, and the group will all work together to kind of problem solve on some of these. So we want to take what they have presented here and begin to help you apply what you've learned here today. And so we'll do that with a few rounds in the spring, see how that goes, see if there's interest and need in order, that will determine whether or not we would continue that. But be looking for those announcements. Thank you, Erin. Margot?
Thanks. So this was really, really helpful and so interesting. So I'm actually a genomic science liaison for Ambry. And as the person who is a main contact for the clients who are experiencing these frustrations as well, we've really been thinking about, like, how do we educate clients so it's easier for them? So I guess my kind of thought is, like, what do you think the lab's role is in helping providers who are ordering this testing and with that education? Because, our hands are tied a lot. Like, if, we're reviewing medical policies, and I think, like, for UHC, like, a good example is, like, if you write aortic aneurysm in the note, it's not covered. But if you write thoracic aortic aneurysm, it's covered because it rules out abdominal aortic aneurysm. So it's like, I don't think people realize those things. So what do you think labs should be doing to help providers?
I'll just start with one suggestion, and Erin, I'm sure you have so much to share as well. I think one suggestion is labs have access to more data than anybody does. So a clinician can tell you a patient's story for one patient, but between labs and payers, you guys have the genomic data, and then payers have the claims data. So one thing that labs could do is identify the sheer numbers of patients who had certain types of testing, and then invite or share that information with your high ordering or your heartland region clinical providers, and say, hey, did you know you had 40 exome orders for Anthem patients, and Anthem doesn't cover exome? Can we get you together with some other providers that I might know have 100 and 200? Can we all get together and advocate for Anthem to cover? So I think it's the connecting power and the sheer numbers and data, that high volume of who's ordering what, without breaching confidentiality. Can you reach out and do a year-end summary for pain points or tests that providers are encountering, those barriers?
That's really helpful. And actually, it's funny that you bring up Anthem and exome. So our health policies director is a genetic counselor who has payer expertise, and we're actually trying to do that, like, with anyone and everyone. Is like, do basically like a letter writing campaign to Anthem, basically saying, hey, you're not following ACMG guidelines, like, it's not covered. Like, so it's just, like, funny that you bring that up. So if anyone wants to contribute, it's not just for Ambry, it's like for the good of everyone. We would love for anyone to contribute.
That's really great to hear, Margot, that you guys are working on that. And my suggestion is, I mean, it's similar to what Julie mentioned. One thing that I experienced in clinic was that when I would go to get a prior authorization for certain panels, for example, the CPT codes that the laboratory used would maybe not be covered by that particular payer. And that payer would say, well, if it was this CPT code, then we would cover that. And I'm like, okay, that's great. But what lab is using that exact combination of the CPT codes that you cover? And then they would want me, the payer would want me to go back to the laboratory and ask the laboratory if they would consider changing their CPT code for this particular patient so I can have this testing covered, which seems like a weird place to put a provider in, to be honest. Like, it does not feel good as a provider to be put there. And having worked in industry now, I also it would feel very weird to me as you know, having been a representative for a laboratory, for a provider to be put in that position. So I do wish that part of those conversations that Julie's mentioning would also be, you know, including streamlining CPT codes and why, you know, what's covered and why that those payers are covering one code over another when it comes to especially panels. I think it affects panels probably more than exome or genome or microarray, but that would be incredibly helpful so that we're not putting providers in that weird place that is definitely outside of their comfort level and honestly probably outside of the appropriateness for their job role.
And I think something that could be applicable to laboratories and individual clinics or institutions is look at that year-end report. If 97% of your microarray orders were authorized through authorization, go to that payer and request gold carding. Request that from our institution, we can do retrospective audits at whatever you payer feel comfortable, but 97% of our orders are in line with policy. Isn't it a waste of everyone's time to go through this prior authorization process? Can we have gold carding for this test from this institution? And our part, we'll keep educating our providers. That year-end data, it's really powerful, and it has the potential on a laboratory side to say, you know, providers are using our microarray highly appropriately. Can we remove this from prior auth?
Thank you. That's super helpful. Thank you. And again, thank you so much for sharing your expertise. It was really helpful.
Now, make one plug of we have a really great opportunity with the explosion of genetic testing and payers not really being able to keep up with everything. Genetic counselors can embed, and genetics nurses, genetics experts can embed themselves and ingratiate themselves with payers by ordering responsibly, providing proactive education to your payer. Say, hey, exome guidelines and genome guidelines have just been updated. Here's that information. Send it to the policy email at a payer. And for every 10 wonderful interactions, it only takes one stinker to kind of sour the feeling. So one example of that, we used to get prior authorization requests for BRCA 1 and 2 that met policy. But on appeal or post-service review, it was obvious that a full panel had been done. And we had the medical director saying, why are they doing that? Why are they lying? And we tried to explain, you know, that they felt they were meeting policy, this, that, but it only takes one sour note to overcome a lot of positive work. So we can do a lot by internally policing our space and supporting each other in these kind of high level advocacy rather than, you know, yelling at someone over the phone when it probably isn't going to be successful.
This is Luba again. You know, I'm never sure why, if you're getting a prior authorization, why it's not honored. Like, I don't really understand that. So I could see if somebody had a deductible, they didn't know they had a deductible, you know.
Mm-hmm. Most prior authorizations should be honored. The information is consistent. Making sure it's a true prior auth and not just courtesy review is helpful. Most Blues plans, they might not require a prior auth, but they'll do a courtesy review. They're not really under contractual obligations to pay for something that was approved in a courtesy review. But also, if CPT codes don't match, if there's different medical information in what was submitted with the claim than what was submitted with the prior auth, it's really hard for these payers to match prior auth claim. So if there's different information, if you submit 81479 for the prior auth, but it was 81415 on the claim, even though the test is the same and clinical information is the same, it might automatically deny. And you could actually appeal that quite successfully, but it leads to a lot of inefficiency in the system. I totally agree, and puts you guys in the hot seat.
Right, exactly. Yeah, it's very, very interesting. Thank you. I think this should be a required thing for everybody in a training program.
It's a very powerful discussion. Yes, go ahead, Lori.
Oh, I was just going to tell Luba she's reading my mind. I've heard this presentation and I will be notifying our program directors, because I think, and I'll notify the other program directors that this is available on our website. I think this is just so important for genetic counselors in training to have this information. And like Luba, I wish I knew all of this a long time ago.
And also in this world of the use of these genetic assistants who are, supporting us in our roles, having this kind of maybe an on-demand webinar where we can say to a new, or even anybody who's in that role, and say, here, you need to listen to this.
We're at the top of the hour. Really, really appreciate all the discussion. Thank you for everyone for your time. Reach out to me, Julie, Erin, Lori, any of us. We can all help with any kind of questions you might think of, and then look forward to an email from me and early next week to give us some feedback on what you learned, what we could do better. And we really thank you for your time. So have a great day, good weekend, and we'll see you later. Take care.
Thank you.
Well,